Should be good.
Good morning. It's a beautiful day out and we have great panelists, so we're excited to be here. My name is Jean Nagelkirk and I'm the Vice Provost for Health at Grand Valley State University. On behalf of the West Michigan Health Forum partners, which include Michigan State University College of Human Medicine, the Blue Cross Blue Shield of Michigan, the Midwest Interprofessional Practice Education Research Center, and the Michigan Improvement Consortium, welcome to today's topic on virtual health and emerging technologies. The monthly fora that we have are designed to discuss information on the delivery of healthcare systems and the improvement of health in our communities. It provides a great opportunity for our students, faculty, business leaders, community leaders, elected officials to come together and look at those challenging problems that we face in health and what we're doing as panels and as individuals to improve the health of our community. Grand Valley is especially pleased to co-host these events as we have over a third of our students and a third of our 25,460 students in one of our 75 health-related programs. This venue gives them a great opportunity to learn and to understand more challenges for our healthcare. West Michigan Grand Valley is the leading provider of students for health professions, so we're especially pleased that they will be our talent pipeline for our communities in Michigan and in the nation, so that when you go and get quality health care, you may just get one of our students. We also want to thank each of you and for your organizations for providing clinical placements for our students. This is where they learn to become skilled clinicians. And we have Ferris Pharmacy students, we have medical students from Michigan State, and Grand Valley's Nursing and Health Professional Program. You do a great job in helping with that. For those of you who are interested in developing interprofessional clinical placements where 2 or more of our member learners would practice together in a clinical setting to do team-based care, we'd like you to let us know if you're interested because we'll help design that for you. Katie Branch, if you could stand, Katie, she's in the back. She is the point for that and can help us develop those clinical sites. Today, we are going to be hearing expert panelists discuss opportunities, challenges, and models of virtual health and technology in healthcare. Our expert panelists will share information about how and to what extent our health records are interconnected and accessible to our variety of healthcare providers. We will learn about health visits, the complexities and the opportunities for patients and for clinicians, and information will be provided on how and what technologies can assist in monitoring individuals with chronic health needs. Before we begin our program, I would like to thank Blue Cross Blue Shield of Michigan for sponsoring the event and the breakfast. And I know David Brown, if you can wave your hand, he is here. Thank you, Dave. And a special thank you for Katie Branch and Diane Dykstra, who coordinated and organized this event for us. I would also like to recognize Sue Niebuhr, who will serve as our moderator today. Grand Valley is fortunate to have Sue. She is serving as our first executive in residence for the Masters of Health Administration program. She is also president of Catalyst One Consulting. Please join me in welcoming Sue, who will introduce our panelists.
Well, good morning and welcome. It is an exciting morning. This topic is so timely because healthcare is changing so fast, and this is the direction it's going. It is the future of healthcare for us. And I know a lot of our students are out there listening to this program or here this morning. And so I'm just really excited to hear also what our speakers have to say. So I'd like to introduce them. First, we have Tim Pletcher. He is the Executive Director of the Michigan Health Information Network Shared Services, or MIHIN, a public and private nonprofit collaboration dedicated to improving the healthcare experience, improving quality, and decreasing costs for Michigan's people by making valuable data available at the point of care through statewide health information sharing. And we know that's very important for our future. Tim will be presenting an overview of the Michigan Health Information Network, how the exchanges are connected, and the benefits of MIHIN to the payers, providers, and patients. And then next we have Doug Dietzman, is Executive Director of Great Lakes Health Connect, or GLHC, Michigan's largest health information organization, and one of the most successful privately sustainable HIOs in the nation. Covering a wide majority of the hospitals, provider organizations, and other healthcare stakeholders across the state, GLHC's nonprofit 501c3 mission is to further the collaborative development of care-connected communities in each local setting to advance the health of Michigan citizens. Doug will be giving us an overview of GLHC and how it fits into the MyHIN. Joe Brennan is with us, is the Senior Director for MedNow at Spectrum Health. He has been instrumental in the creation and development of the most robust telehealth program in the state of Michigan. Joe will give us an overview of MedNow, statistics on the typical user and type of care, virtual tools used for patient monitoring and maintenance of chronic disease, and how MedNow services are billed. And last but not least, we have Ken Johnson, MD, is currently the Chief Medical Officer of Emergency Care Specialist and the Vice President of the Medical Staff Leadership Committee at Spectrum Health Grand Rapids. And he will be giving us an overview of Answer Healthcare on Demand, a newer product. And actually, I had not heard of that one until this morning, so I'm anxious to hear about Healthcare on Demand. And he will also be sharing the medical provider's perspective on how the use of the telemedicine virtual health improves patient engagement, overall care, and lowers unnecessary healthcare costs. There will be time at the end of their presentations for questions, so please jot down your questions as we go along, and afterwards we'll have mics for you to answer those questions, and hopefully we'll have a lively discussion afterwards. So join me now in welcoming our panel.
Good morning. Thank you very much for that kind introduction. The slides turn very, very slowly because of the recording, so if we get out of sync, I'll try to click that. I'm Tim Fletcher. I'm the Executive Director for the Michigan Health Information Network, and we are focused in this state on really creating infrastructure. And if you look at this picture on one side, you're still getting the job done. But you're not really preparing for the future unless you're building infrastructure that can scale in a massive way. And clearly this is better, but it's not just better because of the technology or for the technology. It's because of all the socio-technical or the non-technology reasons that you can afford to put that kind of infrastructure in place and maintain the standards and maintain the consistency of keeping the lights on. MyHIN, you read our mission. Probably the most important thing that we're going to see today, and is part of this mission to pay attention to, is the point of care is moving. It is moving to be everywhere and in a very distributed way. And so freeing that data, having the liquidity of the information so it can go to all of those new novel places that the point of care goes, is really important. To that end, the Michigan Health Information Network really doesn't think of itself as an HIE. It thinks of itself much more as an ecosystem. And that ecosystem is really serving as the focal point for integration for everyone. We refer to this as a network of networks. We finally have all of the health plans in Michigan sort of under the same legal connectivity structure and organized in a cohesive way, including 10 of the prepaid inpatient health plans that are sort of the carve-out for mental health, 8 of which are finally actually receiving information and doing things around the point of care for transitions of care. We also serve as the single point of entry into the state of Michigan. There's sort of a shared responsibility where the state is organizing all of its different components inside the state so that when it comes to the outside world, it looks more and more like one consistent entity. And then we provide this cyber security type control point for what comes in and out, and that helps the state protect itself and really align its resources. We then connect to a growing mass of other trusted data sharing organizations. There are 11 qualified health information exchanges. Great Lakes is by far the largest and sends us the most data compared to everybody else. But there are 11 other ones, and what we're seeing is they're all doing different kinds of things. We have a whole new explosion of sort of consumer qualified organizations that are really trying to tap into the flow of information and really be part of this ecosystem. And then we have connectivity to the national footprint through the eHealth Exchange, through things like Commonwealth, other entities that are trying to operate on a more national basis. But this ecosystem is really the foundation of what we're promoting and advancing. And we do that as much through technology as we do through the legal chain of trust. And by that, we have a robust set of legal instruments, well beyond a business associate agreement, which is a very narrow and simple infrastructure component. But when you look at the banking industry, when you look at any other mature industry for data sharing, there is a whole wealth of disciplined documentation that defines how these legal bilateral agreements are put in place. What happens when the money comes out of an ATM machine incorrectly? Who pays the interest as things move back and forth? What happens during currency exchange? There's lots more to this infrastructure for data sharing. So we have what's called a two-tiered approach, a master agreement and then a data sharing agreement that chops up into what we call use cases, all the different ways to share information. And it defines them in a very clear way, legally, technically, and from an implementation appropriate use kind of perspective. And the other big thing with data sharing is everybody seems to want to do everything at the same time, which is impossible. So what we've developed is what we call the use case factory, which is a statewide prioritization process for these use cases to sort of propagate through. And as they have funding and resources and support in terms of buy-in to actually do, they advance to the different stages, or they get stuck at that prior stage gate. When you look at that, it creates a pipeline of what kind of data sharing is possible, where at the far end, it's pervasive, it's happening in the high 90% type level. And as you get into the blue here, those are all happening and they're in production, but they're not pervasive. Down to these ones in yellow, like death notices, are just being worked on and figured out. What are the legal issues? What's the best technical way to deliver things? Back to these conceptual ones, of which there are many more than are shown here, which are things people were willing to write up, but you couldn't really find a sponsor for, or you couldn't find anybody to create carrots or sticks to sort of motivate it to happen in a broad way. So they're great ideas, medically maybe even very important, but there's no mechanism to advance them. So the analogy for these use cases that seems to work best is a transition from sort of break bulk shipping, where we organize things well, we put them into the right cargo bays, and then when they got to the dock, we started pulling things off. And there were a lot of people involved, a lot of hands had to touch things. And we ended up making a transition to container shipping, where we really defined a set of containers for how things were working. And it's beyond the actual technology components of what's in there. It's more of the functional, how's it going to move, so that it can move from the different settings very easily without necessarily somebody opening up the box. And that's a key part at my end, where we might add stuff, add another box to the end, but we're not necessarily storing all the information. We're really trying to move things through where it needs to go as quickly as possible. So if we look at a common scenario of a transition of care, where someone's going to the hospital, we're trying to notify someone that that patient's been discharged, or there's a good opportunity for care coordination, we put a couple use cases together. An admission, discharge, and transfer use case, the active care relationship, and the statewide health provider directory, where we put these three pieces together to create a notification infrastructure. At the heart of that is something very fundamental in Michigan that we're doing, which is the next generation of attribution. That's the linking of which doctors or which providers or which caregivers in the community go with which individuals. And that will eventually extend to which caregivers are taking care of patients that are maybe family members or something. But right now it's that basic linkage. We get every month literally millions of this line where we just get the identifiers for the patient, for the primary care provider, and we get all of the network information for how this provider fits into the rest of the ecosystem, the affiliation structure. We get back in July, we get about 11.5 million of these now from all over the state. We're increasingly getting active care relationships now from all of the health plans. They're just about to start, so that we will have this full 360-degree view of exactly who's interacting with the patient. So when you put those kinds of things together and you have that infrastructure very clear, you can begin to take a notification match who are all the entities or individuals that have relationships with that patient, and generate a notification based on how they're configured in the health provider directory. Where would they like things sent? How would they like things sent? To what HIE? To what direct secure messaging address or other endpoint? And then it can be redistributed. We get almost 100% of all the admission discharges in the state. About half of those half of the discharges from all of the skilled nursing facilities in the state now. You can then add other use cases to this exact same process, and it repeats itself, so it becomes an easily digestible and learned activity for providers. Part of what we're trying to do with this scalability is a recognition that historically folks have really struggled to find information. And you behave differently when you're struggling to find information. But with the adoption of EHRs, which has been dramatic since meaningful use kicked in, where almost all the hospitals have data, and about 75, 78%, depending on whose statistics you believe, of all of the ambulatory providers are now on EHRs of some sort. The availability of electronic information is becoming pervasive. It's certainly reached critical mass. It doesn't mean it's good information, it just means it's now all available. And when you have this flood of information and the dynamics change, suddenly we're very interested now in how do we get quality data? And what out of this mass do we want? And then when we get it, how are we going to effectively use what we're getting? Become the dominant activity. And that's really the stage that the world's at now. So we're believing, based on what's been done with the admissions, discharges, and transfers, that basically we're getting all of these. We're asking hospitals and skilled nursing facilities, every time you touch the patient on the way in, when they leave, as you transition, send this. Don't even think about it, just send it. Get it to a predetermined destination. We are now doing the exact same thing with care summaries. So we are actually saying send at the time of discharge all of your care summaries. And again, just send it to one spot and we'll take care of redistributing it to where it goes. This is very similar to the Federal Express model. Just send everything to one spot and then sort it out and reroute it. And we have the technology of scale to do that now. And what we're doing, though, because these care summaries are big, unwieldy, ugly documents that are highly inconsistent across EHRs, is we're saying let's start and just get the medications, the problem list, and the allergies clean and consistent and good, and we'll propagate that. And then next year, we'll work on cleaning up the care plan. And the next year, we'll work on cleaning up the diagnostic information. And the year after that, we'll work on advanced directives so that we're chunking away at this big, unwieldy document. And we're doing that because the workflow process associated with cleaning up those documents is much bigger than the actual format of the data. It's not as simple as just saying put it in the right spot. To find it, they have to change their workflow in the business often to be able to even know where to pull it from in their EHR. We also made a major change where we simplified even further how they send things. How many people in this room are familiar with direct secure messaging? Okay. So direct secure messaging, we basically said send all those to a direct, one mailbox in the sky. Just send them all to that. Don't have to do any logic or special routing, and then you can deliver it there. And we'll take care of getting it to all the other places that it needs to go. So we pretty much believe that over the next year, we'll create additional incentives to motivate folks to really, in the ambulatory setting, pretty much say, whenever you touch a patient in the state of Michigan, send your information to one predetermined spot. And based on the active care relationship infrastructure, we will redistribute it to all the folks who have a proper relationship to be able to receive that information. We are at 70% of all of the discharge summaries now. Probably by the end of December, we'll be in the high 90s. So we'll have pervasive inpatient world, and then next year we'll start on the ambulatory setting. Okay? The other big area we spend a lot of time are provider burdens. There are many. In my opinion, the source of burdens for most providers comes from government and comes from health plans. And so what we are focused on is taking some of those burdens, of which they're well documented to be very expensive, and try to streamline them. The most significant area we've identified is around the area of quality measures. and the inconsistency of quality measures and the inconsistency of how every single provider is asked to do something single health plan in every different government entity. And this comes crystal clear home when you look at a Venn diagram of all the different quality programs, and you see that out of 400 or 500, only 3 measures are in common, which seems frightening, but it's even, but that's good news actually, is that they're actually starting with a new program like CPC Plus to actually try to get some reuse, so that went up, so to give them fair credit, okay? But what's bad still is even for those 3 measures, they all do it a different way at the transport level of how to deliver that. So every provider has to build a different infrastructure or hire somebody to make an interface for each different health plan they do business with. So again, we've streamlined that so there's a common submission mechanism for this supplemental clinical information so that they can go from an interface for every single health plan to an interface one time, where they send all of their quality information, and we use the active care relationship infrastructure to break it apart and then route it to all the different health plans themselves, so that they get, in some cases, more information because it's simpler and it's now being divided up by the active care relationships infrastructure. And we also have a new opportunity to focus on closing gaps of care versus sending files in very different formats back and forth. And so as these physician organizations send their supplemental clinical information in a standardized format, we're also getting the health plans to standardize what a gap in care message looks like coming back so that the gaps come back in a consistent way, because those were all happening completely different ways for every single payer. Then they can close the gap by sending, here's the response to a legitimate gap in care versus missing data. But we're also then able to use the active care relationship to take that gap and send it to other providers who know or have information about that patient and can then essentially close the gap. So it's not just the one that the payer has attributed through some algorithm. With that, thank you very much, and I'll turn things over to Doug.
Thank you. Good to be here this morning. Good to be back, I guess, at some level, back when what was then Michigan Health Connect was starting here in West Michigan. One of the things that we promised the Alliance for Health is we'd come back every year and provide an update kind of on what we were doing and where we were at. So at some level, this is kind of coming back to fulfill that promise at some level, and want to give you a little overview as to where we are, as well as some of the ways in the context of the agenda this morning about thinking about technology and where it's going, kind of how we're doing that and what we're seeing. Really focused on connecting communities and being very focused on that. Some of our origins, competing healthcare organizations came together to say, we can compete in lots of different places, but we're not going to compete. Can we agree we will not compete as it relates to clinical data exchange and how data gets from one place to another to support patients as they move between us? Spectrum Health, Metro, Trinity here in Grand Rapids, along with a few others early on, came together under that principle and said, we're going to put money in a pot and figure out how we can make that happen. So collaboration in this community, as we know, for those of us that have been here for a long time, is a core part of what makes West Michigan cool. And it grew out of that to say there's got to be a better way that we can do things for folks, and we've been trying to live that out ever since. And it's really focused on solving very local problems. One of the principles that we said early on as I looked at what was going on as it relates to health information exchange is there was an exchange in Maryland that started up, did a whole bunch of cool use cases, did some cool things with the government and stuff like that, then turned around to the provider community and said, okay, now it's your turn to start paying us. And the provider community said, well, we don't want that stuff. That's not what solves the problem for us. And they actually, like overnight, went out of business and said, well, I don't think that's the way we want to start this thing. So we started it like any other business would, and we've continued to this day to operate like any other business would, which is if we can't provide value, if we can't solve problems that the provider community, broadly speaking, is willing to pay us for, to help solve those problems, then we shouldn't exist and we'll go away. So we have the same burden that any other business would in figuring out how we do that, because we're funded by the business that we provide, not by the taxpayers or others that are just kind of giving us money and hoping good things kind of happen. And technology that makes a real difference. We're going to hear some things from the other two gentlemen that I'm sure, as well as Tim, on specific ways that technology is actually making a real difference for folks. Because if we don't do that, technology for its own sake is useless. That doesn't do anybody any good. It just adds confusion to the mix, and it's already very confusing out there. So being very targeted with the technology is kind of the core component. And why? I don't have time this morning because I'll get the signs in back eventually to go into all of these, but 3 stories that I've told across the state often. My son, who ended up having pancreatitis attacks on a regular basis when he was young, and into the hospital many times, multiple physicians, and my wife and I in the position of carrying his binder around to make sure he didn't get an extra poke, and the trauma. And Rose knows very well about that because Ethan was in her practice and trying to figure out what's going on with him. My father-in-law, who's in the lower right, who's the classic old dude with lots of problems, and going from doctor to doctor to doctor for the diabetes and congestive heart failure and all those sorts of things. And how does that community stay tied together in a way, besides my wife, again, having to carry the binder around to make sure that everybody knows what it is they need to know. And by the way, he doesn't necessarily know where he's going. So if we're expecting to be really good at anticipating where folks go and distribute data so that it's sitting there waiting, we're ultimately going to lose, because folks go where you don't know they're going to go. And so how do we make sure the information is there as well to take care of folks when they show up? And then the other pictures, myself and my wife, and my parents' 50th wedding anniversary, our 25th wedding anniversary, had a big party planned. My mom was planning it. I ended up getting diagnosed a month earlier with prostate cancer. That's in 2013. And in this picture, she didn't know, I hadn't told my parents yet, that was going on, because I didn't want to ruin that day for her that she was looking forward to, but put me in a very personal position of figuring out, how do I collect up my records, because I got to go somewhere and get this thing taken care of. So all of this stuff about technology is cool, and I'm about to dive into stuff that may make the eyes want to roll, but it's for a purpose. It's to solve these, and you can put your own pictures on the screen, because ultimately that's what it's all about. So we want to improve outcomes, we want to make a difference, and make sure that the information is where it needs to be, where care is delivered or managed. Just from an overall standpoint, we have 129 hospitals across the state now, about 85% of the acute care beds, connected a whole bunch of other locations across community mental health, local public health, primary specialty care. Food bank is attached to the network because they get referrals for nutritional assistance. And doing well in advancing the network across the state. And ultimately, our ecosystem is community-wide. We talk about state, but it's about every community, physical, behavioral, social. We're talking a lot about the social determinants of health. How does that all get tied together in a way through workflow, the relationships, how things need to run and operate specific to each organization? Because each dot around the slide, around the circle, has their own strategy, has their own business requirements, have their own funders and things that they need to do to be successful. And so our role is not to come in and say, we've thought this out and we think we have the right answer that's going to work for everybody. Our job is to go in and say, what are you trying to accomplish? How do you serve the folks that you serve? And how can we help you do that better in a way that elevates what you're doing? And on a communal basis, then, with everybody being elevated, we get what we're looking for kind of across the board. So 3 technology domains, just to kind of simplify things. We've got to push some stuff around. We need to query for it sometimes. And then as we've got the data, we need to start looking at the data to say, what can we figure out about it? So we've talked about some of these, again, in the past of the updates for you guys, but results delivery, we're bringing in over 70 million messages a month now across the various types of messages that we're bringing in to the platform, distributing that many out again, so large volumes. Delivering results directly to the EMR, ADT notifications through the MyHIN service or our own that supplements kind of what we get from them. The CCDs, CDAs that are new, continuing to push those around and learn better how to do it. The pushing of them aren't as hard as the folks on the other end who are receiving them going, oh my goodness, now what do I do? Thank you for sending it to me, but now ingesting it into the workflow, ingesting it in a way that actually works to support that practice. That's the challenge of not just the CCDs, but the ADTs and the path that most organizations have been on over the last couple of years to figure out how to even deal with those. Referrals, almost 1,300 offices now across the state connected to a closed loop referral network, so we can manage who's going where. We can keep in sync as things are going on through those transitions. Clinical messaging and orders. Now the question you should be asking, hopefully, is, so what? Because if I get up and all I talk about is numbers, if it's not actually making a difference, then it's pointless. It's useless. So we've got a couple large offices here in West Michigan that are transacting over 1,000 referrals a month. Now imagine 1,000 referrals a month that you're managing in an office by phone or by fax and trying to keep track of everything in those 1,000 that went on. What's the status? Did the patient show up? What happened? Did we get the information back we're supposed to get? Did the patient even show up in the first place, or do we need to follow up 1,000 times? And then you get to do it 1,000 times next month. So the real value there to them is they now finally have visibility and can actually manage all of that inbound and outbound activity in a way that helps make sure that patients aren't falling through the cracks and that all the right information that's needed to deal with their transitions are being handled appropriately. And then we've got over 100 just here in West Michigan. We've got over 550 across the state that are getting real-time results directly into their EMR, which makes sure that from a patient care standpoint, the results are known right now. Patients can be contacted right now. We can be tracking and monitoring those, and we eliminate the manual transcription errors of doing things by hand. So the second thing is in the poll, the longitudinal health record, being able to walk into an emergency department, have that emergency department say, what do we know about Doug from everywhere across the state where he has transacted, is not a pipe dream anymore. We have over 7 million now people in the MPI. We have 7 to 8 million clinical messages a month feeding the repository, all with a purpose of making sure that that data is where it needs to be. We've also added advanced care documents. I was talking with Carol Robinson here this morning from Making Choices Michigan, who's spearheading and pushing and leading having the conversation with folks about where they want their care, how they want their end-of-life care kind of managed and delivered. But once we get them, where do we put them? And so we're a place where those are being put alongside the clinical information to make sure it's available. Immunization query with MyHIN, the Health Exchange Patient-Centered Data Home is something for networks across state lines that we're working on to connect to Indiana, to connect to Ohio, and make sure that we're doing the right things there. And on the so what basis for this, there's a couple things, and these will be in the slides that I'm sure will be available to you, so I'm not going to read through them in the interest of time now. But Dr. Kara Poland, who deals with the very complex patients with high levels of substance behavioral health abuse in the community, has a quote here where it talks about them being able to make more informed decisions. When they every morning when they look at their schedule to see who's coming in the morning, they take a look at our community health record first, Viper. And she told a story about a woman who was coming in complaining of head stuff, pain, wanted to have some CT scans. And this is where things don't work in the community today that we're going to fix. But she looked in there, and that woman had been to all 3 emergency departments in town the previous week on successive days and had a CT scan done at all 3 places. Recent story. All the technology, all the EMRs, all of that stuff, but not connected in a way where we could identify and see that that woman had been in there and been scanned that many times. So that's an example of how we need to do better. But what giving this access to her says is, now I know that. Now I can see things, and I can make sure I'm not sending her for more testing because I can see that a whole bunch was already done. And then gentleman, Dan Roper from St. Mary's, about how they're using it in the emergency room there. So last, make sure I stay on my time, to evaluate the data, either on an enterprise basis or on a community-wide basis. So there are folks in the community now that maybe are hopping from facility to facility, provider to provider, may not have a home, may not have insurance at all, and today there's not a place for them to really be identified because their data is scattered across all sorts of different providers. One of the things now that we can do with that data coming into a single spot is we have a view to these folks. And from an example, so let's talk about the super utilizers as an example, and something that we're working on with the folks in Flint. We can take a look at the folks that have been to all 3 emergency departments in town 10 or more times, or however many times over the last year or month. And if we can identify those folks and then start asking the questions at a community level, is this person in a home? If they're not, let's get them in one. If they are, can we talk to the provider home and say, do you need some additional supports? And if we can do that and run that report on a daily or weekly basis where nobody shows up on it because everybody is being managed out in the provider setting where it needs to be done, we will make a huge difference. But we can't do that until today, where we have all the data flowing in and we have visibility to some of these things. So a few final thoughts, the last couple minutes. One, interoperability is a means, it's not an end goal. It gets talked about a lot today that the whole point of what we're trying to do is just make things interoperable. Or we're just trying to do HIE or implement technology for technology's sake. Interoperability is just a means. Our goal is to improve the health of the community. Our goal is to help make sure people don't get those chronic diseases and stay in as least acute setting as we can possibly keep them. Technology can help enable that, but it's just an enabler, and we need to make sure we keep it in the right spot. No healthcare stakeholder is a self-contained island. Despite what Epic might have us want to believe, or other of the vendors, that they have everything solved. We're in a multi-vendor, multi-stakeholder community and will be forever. And we have lots of stakeholders that have no technology at all in their settings. And so how we tie all that together, we have to, and with the advanced payment models that are coming out and the value, focus on value and quality. It used to matter before, if I really cared, what was happening to my patients when they weren't in the 4 walls of my practice. But to the extent that we are now managing populations and at risk for what happens, I care a whole lot more now what happens when those people aren't in the 4 walls of my practice, because what's happening out there may affect me big time. And that's some of the view. We have to have a view that's broader than ourselves. A consolidated longitudinal health record is vital to care delivery and management. We can't be good enough to know where everybody's going to show up to try and pass data around and assume it's going to be where it is. And it gets us in a point-to-point world. We're pushing data and everything's a point-to-point and have to be really smart about where we're doing it, which is what we're trying to get out of. A single longitudinal record that everybody sends data to and then knows that they can go to get the information is vital and increasingly being used. Optimal value, as always, is going to be driven by solving local problems, not federal mandates, state mandates. That's been our focus, will continue to be our focus, to actually solve the real problems. And then we have here, hard for maybe you to understand if you're not a student of this, but we have here in Michigan something that is envied across the country when I talk to other states and our peers. We need to leverage that. We have great momentum. We have great solutions and tool sets that are underway. Now we just have to figure out how to use them in a way that actually changes things, so that the pictures I put up here, or the pictures that you mentally put up there for your family, we're actually making a difference for those folks. And with that, I will be done. Thank you.
Hello, my name is Joe Brennan, Senior Director of MedNow. MedNow is Spectrum Health's telehealth program. In 2014, the system made a conscious decision to centralize and standardize the telehealth program. If you think back a couple years ago, that was pretty forward thinking. So I'm going to spend the next couple minutes talking about what we've been able to build over the last 2.5 years. We divide our work into 2 groups. We have what we call direct-to-consumer or on-demand care. This is low acuity primary care, 24 hours a day, 7 days a week, 365 days a year. It is connecting provider to patients on the patient's own device. So think of connecting to a doctor for your sore throat on your smartphone. We also have what we call specialty MedNow. This is traditional telemedicine, clinical space to clinical space. We know that we have world-class specialists here in Grand Rapids, but we need to connect them to the regional hospitals and regional communities that we serve. It's a very busy slide, but this is a representation of what we've been able to build over the last 2.5 years. So that first column is the on-demand or direct-to-consumer. So we're bringing low acuity primary care into the home. But we're also doing it at work. When you think about the advantage this has for large employers, it makes sense for both ends. Instead of taking an employee and sending them off to an office visit, we can keep them on site. And they can go back to the line or back to their desk within minutes as opposed to losing half a day. It's also significantly less expensive for them to have a MedNow visit than it is to go into an office setting, urgent care, or emergency department. We also have opportunities within retail. As we saw earlier, there are people within primary care that were not competition before. When you think of the Walgreens and CVS's of the world, there's going to be more opportunity and more choices for patients to make. So MedNow plays well in the retail space. MedNow in the schools. We started in the Greenville public school system because there was a nurse that had to cover 6 physical locations. We enabled her with MedNow technology. She was then virtually present in all 6. So as opposed to getting in her car when someone falls off the monkey bars or someone has a sore throat, she's virtually present and able to triage within minutes. So those first 6 schools are now 30 schools. We anticipate being within 100 schools by the end of this school year. And so again, taking resources and utilizing technology to meet a need. And that other very busy block right there is to show that we have buy-in from all of our specialists. When you look at other telehealth programs around the country, you have maybe a stroke program and maybe an oncology program and maybe a cardiology program. We now have 29 specialties who all believe that this is a viable way to connect patient and provider. When I talk about low acuity primary care, these are the symptoms that we're talking about. So again, not everything is appropriate to connect patient to provider utilizing technology. 3 years and older was a very heavy lift for us to understand how do you treat a pediatric patient when you're utilizing a smart device. But what we found is this is the list that we started with, but this list is growing. About a month ago, we started lactation consultations. Soon, in the very near future, we'll be able to bring behavioral health into the home. And so when you think about these acuities are where we start, but we're learning that this list can grow even further. And in specialty, clinical space to clinical space, we're allowing patients to remain local. So, and it's always not just the patient, it's family and loved ones that need to travel down whenever anyone is transferred if the resources are in a centrally located space like Grand Rapids. So behavioral health is our highest volume use case. There is a significant need everywhere. But we're in different environments. So when you think of the emergency department, we can bring pediatric intensivists to the 8 regional hospitals that Spectrum Health has. We're also bringing pediatric nephrology and neurology to Bronson. So I believe Dr. Johnson's going to talk about this. This is not a competitive space. This is a collaborative space. Telemedicine provides the opportunity for us to collaborate with one another. We're in the inpatient setting. Infectious disease consults are needed everywhere, but how many infectious disease specialists are there? By utilizing technology, we're able to bring that specialist into the inpatient setting wherever they have the technology. The outpatient setting, that follow-up visit. I'm going to talk in a couple minutes about the experience, but how many people have traveled quite a bit and sat in a waiting room and sat in an exam room for a 10-minute, hey, you look great, come back and see me in 6 months. We can eliminate much of that stress, travel, and discomfort by utilizing technology. And that last is in the home. We're in the home for low acuity primary care, but why can't we bring all of the specialties into the home? If a physical exam is not required, why are we asking you to come to us when we can come to you? There are some changes in reimbursement, some very recent, that will allow us to bring our specialists into the home. But we already do this for post-op follow-ups. So there is tremendous opportunity in both the direct-to-consumer space and the specialty space. So why did Spectrum Health choose in 2014 to dedicate resources to something that not everybody was sure was going to happen? And the idea is that we are the need to move from volume to value. I think everybody in this room would agree that healthcare as it stands today is unsustainable. We need to find lower cost ways to treat our patients. So if we're truly going to transition from a volume-based service to a value-based service, we need to find alternatives. And at MedNow, we believe we found at least a few of them. The other thing that's changed here, and this is from a survey that Cisco put out about a year and a half ago. 8 out of 10 people surveyed are comfortable utilizing technology to connect to their provider. Preconception is that there's a digital divide, and nobody's really comfortable using technology for healthcare. Maybe banking, maybe for running, maybe from other things in their life, but not healthcare, and that's not true. We also know that 68% of Americans have a smart device. And so when we talked about telemedicine a few years ago, it was still expensive equipment that sat in clinical spaces. But what's changed is the technology to connect now lives in everyone's pocket. The New England Journal of Medicine recently published an article about from Dr. Eric Topol, and the stat that stuck with me most was by 2020, 90% of the world's population will have a smart device or access to one. So when you think 6.3 billion people now have the ability to connect to a doctor, we need to have this in place. I talk about lowering the cost of care, and that is one of our primary functions, but how do we do that? So when you take those 14 low acuity conditions and think about what happens when you go into that care setting. When you go into the emergency department, the cost for those conditions is about $370. Your experience as a patient could be a wait anywhere from an hour up to 3. Your copay on average is $150. Urgent care, a little less time, but your copay on average is about $75, and the cost of care is $161. Please don't take any of this as us saying we need to replace the office visit. Face-to-face visits are always necessary and always will be. But for those low acuity conditions, why can't we replace that office visit, which is $100, and an opportunity where you have to take time off of work and go to? We can replace it at a $45 price point with MedNow. And so the reason that I go through all these prices is this is how we understand the cost savings. So every single person who has a MedNow visit, we ask, if this weren't available, where would you have sought care? And if they say emergency department, we know how much we save. If they say office, we know how much they've saved. So on a real-time basis, we can tell you what MedNow is saving. Obviously, being a three-legged stool with Priority Health, there are savings realized, but we can talk to a bigger picture. What is the savings that we're having to healthcare? This slide here is my personal favorite, and it is the reason why we do what we do. We've talked about why this is important for healthcare, but it's also important for the patient. So we have patients in advanced heart failure and blood and marrow transplant that live in Marquette. And so if you live in Marquette, Michigan, and you have an appointment, which again, at times is usually a 10-minute, if you look great, come back and see me in 6 months, you have to travel down, you have to find parking, you have to wait in an exam room, you have to wait and do the entire process in reverse. That experience is 14 and a half hours. So we're also assuming that they're not sleeping over in Grand Rapids. $611.80 of non-medical related expenses. So if you look at the average household income in Marquette, more than half of your 2-week take-home goes to come down once. If you have a blood and marrow transplant, you have to come down 23 times. With MedNow, we can place equipment at Marquette General. And we can take that 14 and a half hours and bring it down to 40 minutes. And we can take $611 and bring it down to 14. So when we ask ourselves on the MedNow team, why are we doing this? This is why we're doing this. We're not making people make the choice of, do I buy groceries this month, or do I go down for my oncology appointment? The impact is not only important for healthcare, but tremendous for our patients. We knew, because this was a risk, that we had to measure everything. So we have a very robust dashboard that measures all aspects of what we do. And so not only encounters, but we have savings to Priority Health, savings to other insurers, the number of new patients to the system that come in because this is available, the likelihood to recommend. Who are our payers? Our number 2 payer for MedNow is self-pay. So what that tells us is that people want the access and convenience of telemedicine, and they're willing to pay for it. This slide just shows what we've been able to do in the last 2.5 years. And the numbers are good. From a national perspective, it puts us in a handful of health systems. And the depth and breadth of what we offer with MedNow is an example of what other health systems are looking to do. But we believe this is just the foundation. This is the start. We have created the building blocks that will allow us to take what that next step is. When we talk about the future, it's the consumer-grade devices. It's the Bluetooth-enabled blood pressure cuff. It's the otoscope that attaches to your cell phone. People are becoming more engaged as a consumer in their health, and they're understanding what their options are. And so we believe that we've created a foundation that will allow us to adapt and provide the care that healthcare needs as we begin to transform. So in the beginning, we set out with 3 goals: open up access, keep care local, and lower the cost of care. And I think with the foundation that we've created and an incredible team at MedNow, we've been able to get there. But we also understand there's a tremendous more amount of work that we need to do. So with that, I will pass it to Dr. Johnson.
Good morning, and thank you for inviting me. I feel like the 4th-string quarterback following these 3 other veterans. Good job, guys. MedNow is doing some amazing things. I've had the privilege the last 25 years of taking care of a lot of people in West Michigan. And I'd like to say I've learned something every day. I've also seen the lack of access that people have had over the years. And I've seen resources misused, and I've seen gaps with communication and coordination of care. And I'm not just talking about people that don't have. You know, my friends tend to say, well, you see all those uninsured people and folks with no primary care, but I've actually seen that when there is coverage. And I often ask myself why somebody couldn't be seen sooner. Maybe I'd be seeing them a little bit sick instead of a lot of bit sick. Or why didn't somebody intervene sooner? Well, it's nobody's fault. Those places are very, very busy, and it's an access issue. Sometimes there's just no availability for a given patient. I'm a member of a team, and I want to share with you briefly how we want to put our efforts and vision to implement a collaborative platform that will let physicians do telemedicine in a cost-effective manner. We'll touch a little bit on the benefits I think can be achieved. Joe has hit on many of those, and also some of the educational challenges. Indeed, there's been rapid growth in this field. We saw some numbers in the previous presentation. One that really hit home with me this spring at the American Telemed Association conference. American Well, one of the larger telehealth networks, their leaders shared a statistic that in the first quarter of 2016, they had seen as many visits as they had the entire year of 2015. And at the end of 2015, they had been kind of excited because 2015 had trumped the prior 8 years combined. So you can really see the growth in that. There's a large national teledoc company, and in 2015 they hit their 1 millionth visit. They've been in business since 2005. And in 2016, they're on pace to hit their 2 millionth visit. So you can see the exponential growth that is occurring. Healthcare's always been expensive, and now the gates are open for everyone, which I think is a really good thing. But that puts a strain on the country's collective wallet. And I think there are 2 solutions. We can either provide less care, or we can provide more efficient care. And I don't think any of us want to do the former. And I've been thinking about the latter for a long time, and I really think that telemedicine and technology is a big part of that answer. For years, I have fielded calls, and now I get text and pictures and FaceTime from family and friends, and I've assisted them with direction, where they best ought to go. I've oftentimes diagnosed things and arranged treatment. Sometimes I simply assure them that they're going to be fine and that this is self-limited and what they're doing is really good. But at times I've been really surprised at the appreciation granted back to me. A gift card or a handwritten letter, which you never get anymore, or word of mouth will get back to me. And I think that was no big deal. I took a couple minutes and I used my skill set and my pattern recognition and what I've learned and seen and heard over the years, and I simply helped you out. But for them, it was so much more. I was readily accessible on my device. I listened. The environment was not rushed. More often than not, they ended up at the right place or avoided the wrong place. Oftentimes they saved time, they saved money, or they were simply reassured. It was late at night, there was an acute condition, they weren't sure what to do, they really wanted to know, they weren't going to sleep, and now we've got them addressed. This all got me thinking and dreaming of could there be a platform or an environment where more people could be served in such a fashion. Employers could benefit, and community organizations could as well. Might there be a win for multiple parties? For the patient who would have ready access, coordinated care, for physicians who could get onto a platform to care for their panel of patients, to collaborate with their colleagues, and for small private practice physicians, sometimes this would be cost prohibitive to design this infrastructure themselves. So this platform might be a way to sustain those small businesses. And I'm not here to tout whether being part of a large group or working for a system or being in private practice is better one way or the other. I'm here to, in our community we have both, and I think that's good and I think that's best for the community. For payers and employers, as Joe outlined, we can certainly be more fiscally responsible. And employees would get more ready access, coordinated care, and member clients of a payer would certainly save. For emergency medicine providers, for us it would be an option to get out of what I describe as the hot kitchen, the high acuity, the high volume, the rush, the multitasking. As you go on in your career, that becomes more difficult. Yet you still have a skill set that can be utilized or can be used when you're on time of injury, a time of illness, or maternity. We could leverage the number we have in this community. For consumers, I'll tell my family or friends, you can use the analogy of a house, and maybe the technology is the foundation, and the collaborative that we're trying to establish is the frame and the roof of that house. And there are lots of rooms being developed in that house with doors that connect to one another and doors to the outside, and these are physician practices. So a patient can come to that house, enter in many ways, have a choice. They could even come in the front entrance, the main foyer, and maybe there's an acute care provider, somebody with that skill set who has pattern recognition, can triage, and direct that patient to the right place of care, possibly evaluate and complete the care, or simply give that reassurance. That home would have really good power lines connecting it to the grid. And by the grid, I mean the organizations we heard about today. Places for health records, other hospitals, other systems, other private practices and physician practices. At times when you enter my home, you may need actual bricks and mortar. As I recognize and learn about your need, I can't handle it virtually. So I would get you to an urgent care or an ED. And I would coordinate that for you and make it a more seamless process. Other times your condition is straightforward, and I can evaluate it, arrange treatment, arrange your follow-up, and if need be, I can get a script or whatever you need to the pharmacy. And again, sometimes what you may have is self-limited, and I can warn you what to watch for and listen for and when you should follow up. You may need specialty care, and if you do, depending on the time of day and the acuity, we can loop in a third party, so your care can be expedited rather than waiting for a consultant or battling the phone tree that we have to do when we get referred. I always think good things happen when people get in front of providers. Employers in 2014, only about 15% had telemed as part of their medical coverage for their employees. That's reported to be, or projected to be, 80 to 90% or more in the next year or so. It's hard for me to look back in healthcare and think of anything that has moved from an idea to the norm in such a quick period of time. There have been estimates nationwide that employers could save $6 billion annually if they better leveraged telemedicine services. On-site occupational health is great, and when they're there during the day or there's enough of an employee base to cover that cost, it's a great thing. But what about the second shift or the third shift or companies that are small? I think leveraging a telemedicine platform would serve those employees very well and really help that employer. All communities across the nation have a dilemma. There are vulnerable populations and there are limited resources. Almost every shift I do at Butterworth, I see somebody from one of the homeless shelters or housing units in Grand Rapids. And those are wonderful organizations. However, their staff may not have the medical knowledge to differentiate what is a self-limited condition and what is something more urgent or emergent. So oftentimes 911 is enacted. Fire, police, EMS arrive. Many times that patient is transported by EMS to me or to the ED, and many times they have a non-urgent condition. That's not only an overuse of EMS and emergency department time and staff, but it takes those resources and limits them or dilutes them for those who may be in need. Nursing home patients have always kind of tugged on my heartstrings. They're often rushed to the ED, again, by expensive EMS due to a perceived problem by the staff. And I'm certainly not picking on the staff at those locations. That staff is typically young. They're in training, kind of going up the healthcare provider ladder. They're taking care of elderly patients with comorbidities, many medications, and they really want to do the right thing. But in the evening or at night, their upline may not be available. The on-call physician may not return that page as quickly as they'd like, and oftentimes family cannot be reached. And I have said for years that a readily available acute care provider, an emergency medicine physician or APP, could and should assist that scenario. If you told me a brief story and you gave me the vitals and the glucose and you let me hone in on their med list or their advanced directive, I could probably help that person in the external care facility. And with what we've heard about today with these data situations where I could go on and look at recent labs, recent imaging, a recent workup, if there was an undefined spell or issue that the staff perceived as concerning, I can read about that, quickly assess the vitals, look at the medicines, and probably prevent a lot of those transfers. And I can get on the phone with that family member or responsible party, and with shared decision making, we can decide if the spell has resolved and the patient's feeling back to normal, vitals are good, everything's fine, we can avoid that expensive transfer. Regarding education, it's very important, and it's got to be done on multiple fronts, as we've heard from the panel members. We have an internship program we started and have our first student helping us with some marketing and our operations. And we did that to provide opportunity for local talent, but also to try to retain recruit and retain local talent. And healthcare human capital is very expensive. All of this technology can be used as a tool, but it's still the person that provides that care. We've worked with Grand Valley and their APP program to develop curriculum because this is a new delivery method. We've always heard through the years of bedside manner. Well, now there is webside manner. And there's ways that you have to really listen to these patients and take a good history. In healthcare, we seem to have moved so much to our labs and our x-rays and our technology when wise veteran physicians will tell you if you listen to the patient, they will tell you exactly what's wrong with them. We have to get better at gleaning information from these other data sites, integrating. And then we have to get better and continue to improve how we downstream care is affected, how we close gaps and how we coordinate care. As Joe said, as we move from fee for service to fee for value, these are all the things that are important. We also have to educate our providers and physicians. In my opinion, there's always been a lack of concordance in healthcare. And by that I mean when people want care and when physicians want to provide care. Emergency medicine is kind of the exception, and maybe that's our winning ticket. We're used to being available 24/7, 365. However, I still have to remind my colleagues to embrace this role of handling anything for anyone at any time. Yes, we do critical care. Yes, we do resuscitations, but you can use your skill set to listen, look at a rash, evaluate a sprain, or other low acuity conditions. I regularly hear about inappropriate ED visits, and I really think that's language we should stop because it may be totally appropriate for the patient. In fact, it may be smart. I saw a person the other day who is a single parent and works a couple of jobs and can't afford to miss any more time at work. And by the time that person is home and makes dinner and does homework and runs kids around, it's 10 o'clock at night, and that's when they have to have a low acuity condition looked at. So what MedNow is doing, what we're trying to do, is really giving that person an access point. I staffed a case in the past year or so with a resident, again, a gentleman with a low acuity condition. It was at 3 in the morning, and he was shaking his head, not being able to comprehend why somebody would come to the ER at 3 in the morning with a cold. Well, that was that person's lunch hour. They work third shift, and when office is open in the morning, this fellow is trying to get his kids to school. When they're open during the day, he is sleeping so he can work that night. So really the only access time for him was at 3 in the morning. So as Joe alluded to, if we as providers and healthcare systems don't provide a lower cost option, we know the retail clinics will, and they have. You only have to look at what CVS has done and what Walgreens is trying to do. Finally, we have to spend time, and I know Joe has, with legislators. They need to listen, learn, and evolve with us. There are positive studies all over the country touting the benefits of telehealth and telemedicine. Yet there are still regulatory roadblocks. Licensing is one of them. There may be risk with any new innovation, but it can be minimized with common sense. I think physicians and healthcare leaders, innovators, must lead this process and help create the clinical guidelines and the regulations, and this is going to require lots of collaboration. Providers are going to have to work together, systems are going to have to work together, and groups that have data are going to have to work together. I agree with what Doug said. There's a time to compete and there's a time to cooperate. We have talked to many people who have tried telemedicine, and their first experience is generally very positive, these early adopters. So I would encourage you to give it a try and share the results. Thank you.
Thank you, panel. I don't know about you, but I'm excited. I mean, how many times do you come to these presentations, you go home and go, what's wrong with healthcare? Oh, here we go again, you know. In my career, which is a long one, I would come away going, why do I do this? Hearing these four people, this is why we do this, right? I mean, I am so encouraged. This is the future of healthcare. We do have a future in healthcare. We have an exciting one and an innovative one. So let's get in there and do it. I don't know why we're so negative all the time. So if anything, walk away today excited for what you heard today. I mean, I'm an old rural healthcare administrator. I was a vice president at Gerber for a long time, tried to get specialists to come to a small rural hospital. Med now. You know, a long time ago, I thought, why can't we have intensivists in our ICU from downtown? You know, it's going to happen. Also, I also had to challenge the medication reconciliation list. How many of you have been on that project for years? Look what's going to happen, you know, with mine. And I can't wait to see my 4 portals as a patient come together somewhere so I don't have to go in to a record, figure out which doctor I saw, which website I have to go in to see my record. It's all going to come together. So I'm excited. I just, you know, anyway, I'll get off my bandwagon, but let's do questions, okay? So what questions do you have for these people? You got to have some. We have mics right here. Raise your hands, and Diane will come in. Katie's back there. Okay, right over here. Mark.
Good morning. Thanks, Sue. Good to see you. Great presentation from all the panelists. Exciting stuff. Just curious, and maybe for Tim and Doug specifically, where do you think we're at currently as far as the percentage of a patient's chart being available to wherever the patient happens to show up? And I guess one of the, as we all know, one of the primary stressors of a family member or patient is being a proper historian. I'm curious as to when we can get to the point, because I think the expectation is getting more and more that patients believe all of that stuff is available electronically to a caregiver. But I suspect when somebody comes to see Ken, it's a pretty low percentage of that information. So just curious, where do you think we're at today, and when do you think we'll get to the point where the patient's entire chart will be available as people have migrated from platform to platform in a primary care office, that kind of thing?
Well, for some folks, and if they're all putting the data in a longitudinal record, they can have that today. For it to be pervasive, I don't know as if it's ever going to completely catch up, because people keep moving further and further where they want to go, and new services and things. But in my own analysis, I think we're probably about 3 or 4 years away from having much better query capability on a pervasive basis. The query tools that are there now are they're sort of last generation technology. So if you're on Epic and the places that you're looking for information, Epic actually has some decent tools to query another Epic place, but they don't really have tools to query everywhere else. Commonwealth is trying to build interoperability into the EHRs. They're making some progress on that, but it's really, really been slow, and it's just the EHRs. And increasingly, I think people's information is going to move to other places. So I think it is, if you want it today, you have to pick a longitudinal record that you and your community are going to put everything in, and you can get high capability there, but you might have to go and look at another tool to get it. It's not necessarily going to flow and be integrated. I think we'll be closer to a Google type situation. In about 3 years, you'll see dramatic changes in that. But it's going to take at least 3 years where you can query a broad range of places and pull things back. But in the short term, the only way I see how to do that is for folks to all agree to put stuff in one spot.
Yeah, I'll add, I guess, another slice to that, which is it depends a little bit on the region. So if we talk about West Michigan, with who's participating, within this record, someone could go in and get a very good look at what the hospitals are contributing. So I think and across the state, I think 65 of the hospitals, many of them the larger systems, are contributing to the record, and we're continuing to add more. I think the slides, when you get out into the ambulatory environment or the long-term care, post-acute care setting, and the data that's being collected there, in the myriad of EMRs that exist, there are standards, but there's nothing that's plug and play, and how each of those choose to use those standards varies. It will probably take us longer, based on where the technology is, where the standards are, to easily and at scale get all of the data out of that extended ambulatory setting and get it in there to round out the record. So we're going after it. We're doing it today. It's just when you connect a hospital, you get a whole bunch with a couple interfaces, and when you go out into the ambulatory environment with 2 docs, 3 docs, you still have the same interface work, but the amount of data is a lot smaller, and you have to do that lots of times. So that's probably one of the limiting factors too for the next few years.
And there's still a lot of people not on an electronic system.
Right.
I mean, in the ambulatory space.
Okay.
This question is for Tim. You mentioned that all 10 prepaid inpatient health plans are now participating with MyHIN. Gave an overview of the state of Michigan's participation as well. I understand there's regulatory barriers to including psychiatric data into MyHIN, and I'm curious if there are efforts being made to include psychiatric episodes of care into active care relationships, and if that's in our foreseeable future.
Sure. So remember, MyHIN doesn't store anything. We push things, and so the position right now that we're taking for behavioral health, substance abuse kinds of things is what we call a one-way mirror, where the behavioral health folks can kind of see everything. So what we're trying to do is push and at least make sure the information can get pushed to them, so the physical health information can find its way to the behavioral health folks. It's not as easy, and it's much more complicated, both legally, to sort of push that back so that the behavioral information can come back to the physical health folks. So our premise has been do everything possible to at least get it pushed to the behavioral health folks who are a little bit higher up in the mountain so they have a better view and can see everything. And at the same time, really pursue electronic consent management combined with the standardized consent form that was sort of signed into law in Michigan, and be able to actually create, through the active care relationship infrastructure, who have patients given access to. And so we just completed, with the Office of National Coordinator and a handful of participants in the state, a consent to share pilot to see how would that work. There are places where the community is using Viper, using some other local tools, and basically established their own kind of semi-manual process to manage consent today, to sort of let everybody see things. But we're trying to do both angles. We're trying to have folks do very manual workarounds for that, but then get them on a track for standardized consent and essentially a full-blown electronic consent. But the consumers have to be very involved in that. And in order to get consumers to be able to say, yes, I give consent for anybody in the state to look at something, we have to be very, very confident we know who that person is when we accept that consent, which means we then have to sort of authenticate who they are. And then when we go around and sort of pull up information or route it, we have to match very, very, with very, very high confidence before we route that information. And those are the two infrastructure pieces we're working on right now to be able to get to that next level of scale, particularly for behavioral health. Right now, the PHPs are in that one-way mirror mode where they're just receiving things.
I think my question is for Doug.
Carl, thank you.
My doctor retired, so I finally found another doctor that would take a Medicare patient, and now I'm trying to get my information from one doctor to another. The doctor who agreed to take me sends me an 8-page form that I fill out with all kinds of information on it, and then I have to fill out a couple of other forms apparently to give the other doctor the authority to send my record. What is actually happening there? Are they faxing to each other? It seems to me that there must be a way to put my name and a couple of other pieces of data into it to simply send the record, which I believe exists.
Yeah, I mean, there are electronic ways that could be done today. So, you know, I would say even when I was trying to collect my own information to get it over to Mayo, you know, kind of for my own stuff, doctor could package that up. The EMR that they're using in your current practice probably has the ability to produce a CCD, produce a summary record, and then be able to use direct or some other method to electronically email in a healthcare secure way that information over to the new provider who could take that information and ingest it then within their system. That's pretty low hanging fruit today. The challenge I think in most of the offices is they're so up to here with the business of healthcare and the practice of healthcare being thrown up in the air that understanding exactly how to do that and having incorporated it into their workflow is probably something that they're still pretty challenged with. So it wouldn't surprise me at all if, you know, they print stuff out, fax it over to the other office and have them do something with it. I think more and more what I've seen even over the last few years, if I go back 2 or 3, the clouds were really thick. Folks weren't kind of understanding. The fog is starting to clear a little bit. It's not fully clear as to how to use these things, but folks, the offices have been using EMRs enough now where they're starting to get a feel for it, and I think it's going to be better. But you know, you may need to push them and ask them a little bit and say, hey, send a CCD over to my doc and see what kind of look you get on the face of the folks in the office as to whether they know how to do it or not.
Did your old doctor have a electronic medical record?
I'm a retired physician, but I'm going to speak or question today from the perspective of a patient, and particularly as far as the data gathering that goes into the things about which you've talked so well this morning. My question is for anyone who can answer it. How can we deal with the infernal problem in the clinician's office with limited face time with the physician and his or her need to prioritize, in many cases, entry into the computer, the information that he's getting partially from me when I try to tell him my history and my current problem? Sorry.
It's a good question. It has many facets, and so that I think boiling it down. So there are things that clinicians need to practice medicine that may not necessarily be the things that folks want downstream in collecting and analyzing data and things like that. So I think we're seeing right now a little bit of pressure that we're pushing all the way upstream because we want to do all this stuff back downstream with it, collect all this information for me, and some requirement and expectation that it's actually the physician that has to do it rather than perhaps scribes or others in the office that could do that sort of thing. Personal view from my standpoint is we're working through as a business, so technology could solve it, but until we understand from a process and business perspective what that wants to look like, it's hard to know exactly how to apply it. But I think we're working through what does that clinical team look like? What are the roles of that clinical team? How do we capture the right information within that clinical team that fosters what we need to do within the office to provide the care? And then how do we do that also in a way that facilitates what people are calling that learning health system or some of the things that are needed downstream that may not apply specifically to this setting, but may apply to some other things. And so it's a wholly unsatisfying answer I'm probably giving you right now, other than to say I think that it's recognized and it's something that the clinical practice of medicine is trying to figure out how it's reshaping itself, even with things like what these guys are doing, which is really cool to take that low acuity stuff so that the practice can perhaps focus on the things that are the higher acuity, the more important sort of thing. But now we got data someplace else, you know, too, and how does that all get collected and pulled together? We're trying to figure it out.
And the tools the tools that the historic EHRs have had have really been cumbersome and not, as a technologist, not exciting. Okay, and we watched this in manufacturing. All the manufacturing companies it would implement like an SAP for sort of automation, but they didn't take their top tier, most expensive executives and make them sit down and type into those systems. Okay, in healthcare, we've taken and said, oh, the doctors are the ones that have to do all this data entry. And it is not an efficient thing, but I personally believe only the doctors can lead us out of that path by both complaining about it and saying this is not appropriate for me to do, somebody else should do this. But they've got to be savvy enough to know how the systems work and what gives them better medicine out and what's a better workflow. And we're starting to see that now. Now that we have enough EHR time there, we're starting to see the physician leadership come forward and say, okay, you IT people, you made me do this, this, and this, and you got to stop doing that. This is what I really need to be focusing on. So that's coming, but it's another whole generation of technology. It's better tools and better interfaces.
Ken, do you have any comments?
Tim had a slide that hit home with me with the river of data flowing at you. And I thought, boy, if there could be data sent somewhere and it's kind of scrubbed to give me the pertinent history. For example, recently on a busy shift, juggling 10 or 12 patients, my phone going off, a patient was quite sick. In fact, circling the drain, you might say in ED terminology. Yet she was giving me some history, and she got hung up on the date of whether her third of 4 hemorrhoid surgeries was in 2008 or 2007. That's just, it's I don't need to know that stuff right now when you're septic. In fact, I often tell my own mother, when you go to the doctor, if it's a physical and they got an hour to spend with you, go ahead and get Gavin. But if it's a follow-up visit, all you need to tell them is your age, that you don't have a spleen, and that you're a diabetic. Everything else is really irrelevant. But it is important. I've had folks call me on the phone. I can think about it a year ago, a friend of a friend of a friend, so I don't know this person well, probably 55, called with some side or back pain and hadn't fallen where he'd broken a rib, didn't pee any blood, so I was thinking maybe not a kidney stone, didn't sound infected, no rash like shingles, no cough. But I said to him, have you had a CAT scan in the last year or so? Because, you're of age and you have hypertension or cholesterol, this could be a AAA. I got to send him in. Where if it's somebody younger, well, you don't get a AAA at 30. So if you call me with that kind of a condition, I may be able to make that diagnosis virtually based on pattern recognition in all history. I don't really need any data. So it's really one of those dicey things. How much do you share and when do you need it?
Good morning. Thank you for the program. I'm here today as a consumer in healthcare, and I just had a question regarding the telemedicine. If I say, for instance, I'm covered by Blue Cross Blue Shield, and do I have access to MedNow? If I call in, how am I going to be directed? Or I notice Answer Health on Demand has a coupon for a free visit. Is it something that the market's consumer driven and then we're routed to the right place, or do I have to wait for my employer to have the service available to me?
I can speak from a MedNow perspective. When we started this over 2 years ago, we had to create a model that was $45 up front. $45 was what the market bared, and it is still the price point that most go with. But in the last couple of years, insurers have caught up. So obviously Priority Health reimburses for it. Most it's the same copay that you would have in a doctor's office. But when you think about what we're doing with large employers, employers are choosing to waive that copay. So there's a $0 copay, which not only brings interest, but it's also, it makes sense for them. So if you have Priority Health or Blue Cross Blue Shield, it's whatever your copay is for a primary care office visit. But those that don't have those opportunities, at a $45 price point, we're finding that people are still willing to pay that for the access and convenience.
I agree. I think the payers probably lagged behind initially, but when like the stats Joe shared from the fellow from up north, when you look at those downstream savings, I think they quickly will come on board. I keep waiting for CMS and like the state of Michigan's Medicaid. Like the example I shared, the person from the homeless shelter, I know from my own corporation what I get on a Medicaid patient that goes home from the ED. It's more than a telemed visit. And I know the system, Saints or Metro or Butterworth, gets a sizable facility fee when they come in with a non-specific rash, a sprained ankle, and why they're not covering telemed yet is beyond me. I think they need data. I don't think they want an add-on cost right now. They want to see lots and lots of data and lots of safety and quality and how it works. And once we show them that and prove it, I think it'll be covered.
Okay, our time is almost up. We have one more question.
Yeah, I have a quick question. A community service announcement here. If you're enrolled in a high-qualified, high-deductible health plan that's HSA qualified, you have to have a nominal office visit copay, even for telemedicine. But my question is, there's a school of thought that says you can't manage what you don't measure, right? So data is key. My concern is the quality of the data that's being filtered through millions of times. Are there common naming conventions, or it's clearly the clinical data will speak for itself, the results of a CT scan or what have you, but when you talk about discharge notes and practice notes, how credible is that data? How accurate, how consistent is it?
So I think from a clinical standpoint, it's as accurate as that facility is saying. I mean, it's the documentation. It's the stuff that's being, in many cases, faxed around today or leveraged for use within the facility for treating care. So it's high quality. It is the record. I think where we run into the standardization, normalization question is when we want to start comparing data across different organizations. That's really where it starts to become, can I do that in a way that is accurate and things mean the same? One of the challenges from an exchange standpoint in taking clinical data from various sources and then presuming to normalize it or change it in a way that might make it the same, that's a little bit dicey. I don't know if I want to be changing clinical information and saying these things are the same. I'm a little surprised meaningful use didn't enforce more terminology standardization than it did. I think getting everybody to using LOINC and RX norm, SNOMED, whatever a standard set of stuff coming from the source would have made this downstream stuff a lot easier. So we're doing a little bit of it, understanding the risk and not wanting to go too far that we're doing anything with the clinical data. And I think that with all the value measurement, the stuff Tim talked about with getting the quality measures aligned, it's going to require the data to be good. And I think we'll see a lot of movement to make those code sets a lot more standard in the next year or two.
I mean, just to give you an example of the problem, think of the naming conventions for an emergency department and a hospital, okay? You know, just sending very simple messages. Not everybody calls the same office location the same name. And so when you're trying to figure out, well, which hospital did this patient go to? I can see here that they had an admission or a discharge, but it's a code that says 27. Well, what hospital or what emergency? And standardizing that across all of the hospitals, you know, that's happening, okay? But it's a spiral out where we're taking core chunks and try to get it as broadly standard as possible. And that will be a long time coming. We're not even talking about reconciling all the different ways people do labs and represent panels and try to put them together to display that information. That's it's much harder to do that in an intelligent way, and expensive to do that in an intelligent way.
Okay, thank you. And that wraps it up for today. We have some gifts for you for being part of today's presentation. I want to remind you before we close about the next Health Forum of West Michigan is Friday, November 4th. The topic is Municipal Infrastructure and Health. So come back on the 4th of November and we'll see you then. And thank you for coming today.